All right. Can I get some kind of make sure everyone online can hear me?
Yes.
Okay, excellent. Good. Make this go away. No one wants to look at that, so we'll drag that over here. All right, excellent. All right, everyone, welcome. Happy New Year. Hope you all wrapped up your years well. Thanks for, especially for the people that have braved the weather to come out here today. Everyone else, I hope you're enjoying Pajama Day or however you're joining us online. Um, today is going to be Airway. It's always going to be January, February, because I can't help myself with the dad jokes. Okay. So, as always, the main website, or it's not really a website, it just kind of links you to other stuff because there's not a ton on there. mercymedcon.org. I'll be talking a little bit more about that in just a second. And please follow us on social media. If you're I don't know what the kids are mostly using today. Sorry, we don't have a TikTok, but TH of any EMS on Instagram. And if you're old enough to still be using Facebook, Trinity Health of any EMS on Facebook. But please, it does make a difference to my bosses that we have some interaction on social media. Not even my boss, but like my boss's boss kind of thing. So it does help us look good. So please help me out. By following us on social media. One of the things that does get posted on there is summary points from the M&Ms. So every month, you'll see a summary of the teaching points from the M&Ms posted on there if you are following us, plus other stuff like someone finishes their MedCon sign up as a medic, like I take like a picture with them and congratulate them. So you can like and comment on that kind of stuff as well, is mostly what's on there. Some slides I have to put in for continuing education compliance reasons. No one's taking any money. We went through processes. We followed the rules. Okay, sound good? Great. So mercymedcon.org, as I mentioned before, is now live. That is the QR code just takes you straight to mercymedcon.org. Hopefully that's easy enough to remember. But what we have on there, this is pretty much what the site looks like. If you're able right now, go to there, either scan the QR or pull it up, go to mercymedcon.org and hit that top link, join. That'll take you to joining our email list that we're building. My goal is to send out like a newsletter kind of mailing thing every once in a while, probably quarterly or every other month or so. That it'll just remind you of the upcoming continuing education opportunities that we have, as well as new announcements on protocol changes, drug shortages, that kind of stuff. The idea is that instead of us having to, for basic stuff like that, instead of having to filter it through the leadership at your various agencies and organizations, we can get it directly out to you to relieve some of the administrative burden on them, as well as relieve the game of telephone. So you're getting it directly from us. Other stuff you'll find at that link, requesting follow-up, okay? So if you have a case that, oh, that's not working correctly. If you have a case that you wanted follow-up on, that is not how that is supposed to be working. Okay, so if you have a case that you want to get follow-up on, you click on the follow-up link, and that'll take you to a web form that you just put in the patient information, and we'll tell you what happens with the patient. If you have a specific question, like, hey, can you look at this? And like, I don't know, like someone sent me a case, they're like, so this was the case, and I wasn't sure if it was COPD or CHF, and like, I don't know, would you have given steroids? And so like, I reviewed the case, and I emailed them back, and I said like, I guess I think I would have, and it ended up being CHF, but that's okay. What's one dose of steroids between friends? So you can use it for that kind of stuff, and we review those. Sometimes I wait to do the follow-up, depending on what the question is. I wait to do the follow-up until the patient's like hospital courses kind of happen. So I have some kicking around there, like from last weekend, because the patient's like, we're not really sure what's happened to them yet. Then I kind of want to do it one and done. So I'll try to get back with you within a couple days to a week for those. If you have an interesting case that you think maybe should be featured in an M&M, you can hit the case submission button, and that will allow you to also attach like an EKG or something to the case. Trauma gel, if you're with CHAPE International and you use trauma gel on a patient, There's a QR code on the package that will take you to the form you're supposed to fill out. But if you forget, emergencymedcon.org, trauma jail survey will get you to the same link. And then the education schedule is also on there. So you click that. That takes you to the Trinity page that has everything that we're doing. So that's all the M&Ms, as well as the other offerings from the nursing education side. So they have classes where they are familiarizing our nurses with airway equipment, with critical care drugs. So that's where their nurses are learning about like pressors and all the other stuff and the IV pumps. So if you're doing IFTs anywhere, or you have pressors and maybe you're a little uncomfortable about it, you can sit with some of our nursing colleagues and sit in on the same education they're getting. Doesn't cost anything, and we're working on getting CME numbers for those. Yep, we're working on getting CME numbers for those, so you'll get the hours for showing up. Okay, so it's some additional free CME for that. Other kind of housekeeping stuff used to be that only charge nurses had access to the Pyxis to get you guys restocking meds. Now all nurses have access to the EMS Pyxis. So whoever you give handover to, whoever happens you have find in the hallway, they can log into the Pyxis to pull anything that's not from your NARC kit. So you used a bunch of Zofran, Tor, whatever, they can pull that stuff from the Pyxis for you. You can be fully restocked before you go back out. Okay. Also, if you are calling for MedCon, you have the option of calling us on the phone at either of those phone numbers that are listed there. That line is recorded and meets all of the compliance requirements for having a MedCon conversation. So you do not have to go through CMed. Okay. So that will save you time and headache rather than having to go through CMed. But obviously, if you're on the radio, you're going to still have to get a patch through CMed. But if you have a phone and you have the option, you can call directly, even depending on whatever your policies are for your organization. I don't know if there's a policy against using a personal device to call MedCon. But from a compliance standpoint, from our perspective, there's no reason you couldn't use your personal phone to call us. That still meets all the requirements for it being recorded and everything. Okay. So if that's the easy button for you getting orders, please do that. So as a reminder, Mercy no longer has any labor and delivery services as of early December. So any patient that is post viability, so after about 20 weeks or so, should not come to us. So when you're thinking about the closest appropriate facility, even if the patient has another medical problem that they're there for, you're like, oh, it's a diabetic emergency, they can handle that. We can't, because the patient, even if they're admitted to the hospital for a non-OB related, if they're like within viability, then that patient is going to need fetal monitoring and stuff. We can't do that anymore. Okay. Additionally, if it's even a pre-viability pregnancy related issue, what we're able to offer is very limited. So even if a patient has, for example, and a lot of this is we're still figuring it out, right? But definitely, if someone is post-viability with any kind of problem, they should not come to us, because we do not have the ability to do fetal monitoring if they're admitted to the hospital, or have OB round on the patient while they're admitted to the hospital to make sure baby's doing okay with whatever's going on with mom. For suspected ectopic or heavy bleeding, anything that's GYN related, so heavy vaginal bleeding, any other GYN problem, we still have GYN available. So we can handle that stuff. What is still kind of a gray area is pre-viability pregnancy problems, because we're still kind of feeling that out. It's going to be simplest if they go somewhere else. But some of that stuff we are able to kind of work with our GYN colleagues that are still around to figure out. Because from the hospital's perspective, if they're pre-viable, they're essentially not pregnant with regard to kind of what they kind of need to do. So we're still figuring that out, but that's kind of where things are at now currently. All right. So everyone please scan and log in for the poll questions for our interactivity for the session. I'm going to give you all a second to do that. No longer see phones being held up, so I assume that is working. And all right, so we're getting responses. Oh, I forgot to switch this one to the smiley faces that I normally use now. Okay, good. Polls are working. Excellent. All right, so stuff we're going to talk about today. It's all airway respiratory. We're going to talk anatomy, physiology, pathology, talk about history and physical with your respiratory patients. And then today we'll be talking about BVM and non-invasive ventilation, meaning CPAP, BiPAP, and go through some cases. Next month, we'll be talking about the rest of that stuff, which is supraglottics, intubation, and surgical crike. So anatomy and physiology. So we've got the upper airways. The upper airway is defined as basically everything above the vocal cords. So you've got where your, oh, this is really chafing me that this isn't showing up correctly. You've got the nares up here, which are so that's the nose hole, and then it comes through the turbinates in the nasal cavity, which warms and humidifies the air before it comes down. And then you're starting to get into the pharynx, oropharynx, down past the cords. The cords in an adult are the narrowest part between where the air comes in and getting to the lungs. So that's why when we do a crike, it is below the level of the cords because it's the narrowest part. We assume that if there's an obstruction, it's at or above that. Okay, so this is an MRI of doing basic airway maneuvers. What I want you to take away from this is looking at how the tongue and the soft tissues are moving around as that airway gets manipulated. So really driving home the point of that, head tilt, chin lift, and how that moves it away from the back of the throat and for air to come in. So this is not helpful from an airway perspective, right? All that soft tissue is relaxed, getting pushed against the back of the throat. What is a sniffing position, right? Right, so some people, and what you have learned from your BLS class and from the way that those mannequins are designed is that this is a sniffing position, right? No one says, oh, smell these flowers. Okay, like nobody does that, right? That's not how that works at all, right? When you go to sniff something, you are moving your head forward, parallel to the rest of your body, right? So that's actually this position. This is a real sniffing position. And so the way that you know that you've moved the head far enough is you've got the ear hole even with the front of the chest, okay? And that's an actual sniffing position when you lean forward like that to get a whiff of something. And what that's doing is it's aligning all of the different anatomy so that it's a straight shot to go down, okay? OPAs and NPAs, they're moving soft tissue out of the way. The other thing I'll point out about the NPA is that if you're intubating, you may see it in the back of the throat. Some people don't realize it goes down that far. And then when you go to anybody, you're like, what the hell is that blue thing in the back of their mouth? Okay, it's the NPA you put in. So I've learned that this is like a West Coast or a Utah thing where I was working as a medic before getting here. On the left, the way that hydrant is dressed is what we call the super plug, okay? And so it was an instruction, like if you get on the fire scene, they would say, go take that hydrant, super plug it, right? That was the instruction, that's what it meant. And that was kind of universal throughout the fire service in Utah. Out here, no one knows any clue what I'm talking about. But anyway, so this is what we call the airway super plug, right? So that means 2 NPAs and an OPA. For a patient that's difficult to ventilate, this is before people were really carrying IG-Ls and LMAs, so we didn't really have another option. But if you're BLS and you don't have LMA as an option, or your patient, like, you can't get the LMA in because of whatever reason, this is an option. This is totally valid. And the patient is very easy to bag. So I will ask you, what is the most number of BLS airway adjuncts you've used on a patient? Oh, someone's done the super plug. I love that. Okay. And I'm guessing of the people who did 2, you probably did an NPA and an OPA. Probably not, 2 NPAs. But it's totally valid. You can do all 3. It looks goofy, but hey, if it's dumb and it works, it's not dumb, right? So your lower airways is everything below the cords. So that's your trachea, main stem bronchi, secondary, tertiary bronchi, bronchioles, terminal bronchioles. alveoli, and I throw the diaphragm on there because the diaphragm is part of ventilation, even though it's not part of oxygenation, technically an airway structure. It's close enough though, and it's worth mentioning, okay? So the alveoli, this is where those capillaries actually have gas exchange occur. They have surfactant on the inside, which prevents them from collapsing and sticking together. It kind of is like a dish detergent chemically. And so it helps keep the alveoli open. And when they collapse, that's called atelectasis. There's this lung kind of just going, right, and just collapsing in on itself because it's more like a sponge and like kind of foamy. And it's those cells in the foam just kind of collapsing in on each other. So this is what terminal bronchiole and alveoli look like under a microscope, okay? So then when we zoom in onto the cellular level, this is an alveoli. That's like literally individual cells now that are participating in gas exchange. So you can see right around here, like this is literally the air, and then this is literally the capillary, like 1 cell thick, where the little red blood cells and stuff are coming through there. And that's where the gas exchange is occurring, is across those cells. So respiration is getting the gas, getting the air in and out. Then, you know, the exchange occurs at the alveoli, and then the blood makes it go round and round, right? So inspiration is an active process. The predominant muscle is the diaphragm. The diaphragm contracts and makes the thoracic cavity larger, which drops the pressure, and so you suck the air in. Other muscles that are involved, the accessory muscles, are the intercostals. So the intercostals, when they contract, what they're doing, whoa, I don't know why that happened. When they contract, what they're doing is they're pulling on the ribs, because your ribs are kind of like a handle on a bucket, and they sit down like this. And then when the intercostals are pulling on them, they're contracting and pulling them up. So that's also making the thoracic cavity larger. The larger you make that cavity, the more you're dropping the pressure, the more air you're sucking in. Okay, and then you also have your scalene muscles up at the top, and those are pulling on the very top of the rib cage. And so when someone's really working to breathe and they're tugging, that's what you're feeling, are the scalene muscles here that are pulling on that. Again, body desperately trying to make the chest larger to suck more air in. All right, now oxygenation is the process of getting the oxygen to the tissues. Now, right, inhaled by the lungs, it gets inhaled, comes through the lungs, gas exchange, now blood's going round and round, picked up by red blood cells and offloaded onto the cell, offloaded to the other tissues. Now, I am going to talk about the delivery of oxygen equation, not because I think you should know it, but because it is conceptually helpful for understanding your body's response to hypoxia. So the actual delivery of oxygen to cells is determined by heart rate times stroke volume. Does anyone know another word for that? Cardiac output, okay, times your oxygen saturation, times how much hemoglobin you have, right, makes sense so far, times a big number, plus the partial pressure of oxygen times a little number. So the concept being here that partial pressure of oxygen, how much oxygen is dissolved in the gas itself, plays a very little role in oxygen delivery, and the main driver is oxygen saturation and how much hemoglobin you have, okay? And then what your cardiac output is. So another way of conceptualizing this is like a train, okay? So each train car is a hemoglobin. How full each train car is the saturation, and then how big the train car is, or then how often the train cars are coming by is the cardiac output, okay? So heart rate and stroke volume. Because, you know, heart rate is technically how many trains are coming by, and then stroke volume is really more how long is the train, right? If we're pumping out more blood with each burst, then that's more longer train each time. So we can send the train by more often, we can make the train longer, we can fill up each train car more, are kind of our options for getting that to the cells. Does that analogy make sense? Good. Now, the only direct measurement we have available for this in the field is heart rate and oxygen saturation, both of which you're going to get on your pulse ox, okay? So that's our best measurement for oxygenation. Okay, so we're going to watch a clip. This is a hypoxia demonstration. So this guy is in a chamber where they simulate high altitude to train military pilots to recognize these symptoms of hypoxia in themselves so they can take appropriate steps to mitigate them.
So we're going to start this hypoxia demonstration. Whoever has the toy, if you want to use that for me. So what I'd like for you to do is to pick up a piece, hold it up, show everybody, and tell me what shape it is.
It's a triangle.
All right, so you're going to put it inside the box? Good.
Okay.
Next piece.
Another triangle. Another triangle. Circle. Circle. No, it's a cylinder. It's a cylinder. Cross. Across. Square. Square. That's another cube. This is a cylinder.
We also can see a little purple come around your nose and your lip area.
This is a star.
Now, before we do it again, let's put your pulse ox on your finger. We haven't done that yet. Let's try to check your O2 saturation and see what we're down to. You've been off oxygen now for 2 minutes, by the way.
Roger that.
Don, how you doing over there?
I'm starting to feel like I'm going to black and white and the Looney Tunes kind of thing. My vision is going into just a central spot.
All right, so Don, you can go back on oxygen anytime you want to. You don't have to stay off. I'd like to know what the O2 saturation is on your pulse ox there.
What is it read 70, now? Right?
67.
And he's tachycardic because his body is sending the train by more often to try and compensate for the train cars being less full.
Once you get below 60, death can occur just like that, right? So you got to realize you don't want to die. Can we try the shape box one more time just to compare a difference between when you were just starting your demonstration versus right now? Because we can tell you're really starting to feel the effects of hypoxia.
Triangle?
Yeah, what I'm interested in is to see what kind of coordination he has now.
62%.
Yeah, you've been off oxygen for about 3 minutes 45 seconds. What is that?
Square.
And what was that one?
That is a square.
A square. Are you sure that's this one? Oh, you're starting to have a little shake there, you know, that lack of oxygen. You need to start thinking about getting back on oxygen now, Destin. What would you do? If you felt like you needed to get on oxygen, how would you correct for that? Can you correct for hypoxia for me? All right, so if you don't get on oxygen, you're going to die, right? You're not going to be able to survive this. Go to your regulator, get all 3 switches up on your regulator. All right, go to your regulator, get all 3 switches on your regulator. All right, let's go ahead and put him on for him.
Okay, now watch how quickly he corrects once he's back on oxygen. Okay, color's already improving.
All right, let's continue on with the shape box.
So you're going to square?
Yeah, all right, good
Almost
deal,
finished.
good deal.
Circle?
Look at that. See, that right there proves how much he's already gone from hypoxia back to feeling 100%.
Okay, so it's like pretty immediate, the improvement. Where did I put my remote down? Oh, here. My goodness. On the flip side, ventilation is moving around the carbon dioxide. Okay, ventilation, the CO2, in contrast to the oxygen. Oxygen is pretty much exclusively carried on the hemoglobin, and there's almost nothing that is a part of the partial pressure. Oh, I forgot to mention the partial pressure of the oxygen, how much is dissolved in the fluid of the blood that's not the hemoglobin. That's where hyperbaric oxygen comes into play, because you're increasing the pressure a lot, so you're cramming more oxygen into that other space. But the reason we have to pump the pressure up so high is because it was partial pressure times that tiny number. Okay. On the flip side, carbon dioxide, very easy to dissolve into water, whereas oxygen, hard to dissolve into water, requires a lot of pressure. CO2, very easy. So carbon dioxide is not carried on the hemoglobin. It is almost entirely dissolved in the water component of the blood, right? Carbonated beverage, we all know that. So this is this varies with your minute ventilation, and we measure that with capnography, right? But the important thing to realize here is that capnography is a combination of ventilation and perfusion, okay? Right? So what happens to your CO2 during a cardiac arrest, or the end tidal? What happens to the end tidal during cardiac arrest? Is it high or low? Very low, okay? But how much carbon dioxide do you think there actually is in the blood? A lot, right? The cells are not getting the perfusion they need. So there is a buildup of CO2 in the cells, right? But, so we have a lot of CO2 built up in the blood itself. If you could take a blood sample and run it during the cardiac arrest, the CO2 would be very high. Yet our end tidal is low, and that's because it's a low perfusion state, right? That's why when we get ROSC, we see that big jump in the end tidal, because suddenly the perfusion is now keeping up, and we get a better reflection of the CO2 that's actually in the blood, okay? So when there's a gap between the CO2 in the blood and the end tidal, it's often because of a mismatch between the ventilation and the perfusion. So CO2, your CO2 in the blood is always at least as high, if not higher than your end tidal. So how's this regulated? Again, equation here is just for illustrative purposes, not important that you know it or remember it. Your regulation for this stuff is almost entirely driven by pH. Okay? Carbon dioxide in the blood, it becomes essentially an acid. So you've got CO2 here, it combines with water to produce H plus ions. H plus is an acid, okay? So bicarb, when you add it to this side, becomes carbon dioxide. So if a patient is getting bicarb for whatever reason, it is very important that you are able to ventilate that patient, because that's ultimately how that acid is getting out of the body, is that bicarb joins with an H plus and gets eliminated from the body as CO2 and water. So we have to be able to get that CO2 out. So the predominant influence in your respiratory drive is pH. This is why if you have a pulse oximeter on and you hold your breath as long as you can, the sat doesn't drop, right? It's not that you're becoming hypoxic, it's that you're becoming hypercapnic. Your CO2 is building up, and that is driving down the pH, which is making your brain scream to breathe. This is why free divers hyperventilate before they go on a dive, and that is not to build up their oxygen reserve, it is to drive down their CO2. So they have more space for that CO2 to build up during the dive before their body is screaming at them to breathe. So I will say within the context of EMS that hypoxic drive is essentially a myth, right? Does it happen? Yes, eventually. But if you have a COPD patient and hypoxic drive, blah, 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 and you put them on 15 liters non-rebreather because they're struggling to breathe, which you should, they're not going to become apneic. They're not going to become apneic in the time you have them. They're not going to become apneic in the time I have them in the ER, even counting the hours and hours they're going to be stuck waiting for a hospital bed because of boarding. They're probably not going to become apneic even if that continued through their entire hospital stay. Okay? This takes a long time to develop. So don't worry about it. Now, this drive by pH is also why other states cause hyperventilation, like DKA. So it's the A, the acidosis, that's driving the body to breathe more. And it happens to be that, right, they're acidotic for a different reason, because they have ketones, but the body's compensation is to get rid of CO2, because CO2 is also an acid, right? And so that's how they are trying to compensate for their acidosis, but it's being driven by the acidity in the blood itself. Technically, it's the acidity of the CSF, but the blood and the CSF, they share stuff, right? Because it's all on the insides. Lactic acidosis can also drive it. Any kind of toxicology. There's other toxicology that'll drive this too. A notable exception to acid being the driver is aspirin toxicity, salicylate toxicity. That directly stimulates the ventilatory center of the brain to breathe faster. So that actually starts with a respiratory alkalosis, because someone's stepping on the gas in the brain for some reason, but it's chemicals doing that. So, like we mentioned, you give CO2, or you give bicarb, that becomes CO2. Have you ever given bicarb in an arrest, seen the CO2 bump, and maybe thought that you got ROS, but actually didn't? Doesn't happen often, but it does happen. I'm glad that at least like one person, a couple people have seen it. But that's definitely a possibility. Now, I hope that you are not routinely giving or calling for orders to give bicarb in cardiac arrest, because we know that it doesn't help. It doesn't make a difference. And it is associated with worse outcomes for the most part. It's probably not an effect of the bicarb itself. It's probably a marker of, these are all the patients that, wow, what else do you want to try? Bicarb? They weren't going to make it anyway, bicarb or not. And also, it may be distracting us from doing the more important things, right? If you're worried about giving bicarb to the patient when you should be focusing on high-quality CPR, okay? So, pathophys, hypoxia versus hypercarbia. These are kind of like the problems that you can have, right? So, you can have hypoxia or you can have hypercarbia. So you may have a buildup of CO2 or a deficit of oxygen. That's problematic. You can have lung or thorax problems. You have heart problems, blood problems, vessel problems, or you can have problems with, I call it, essentially you can break this down to lungs, pump, fluid, or pipes. So let's start with lung problems. So asthma, COPD, well, asthma first. Asthma is an inflammatory disease, so the walls get thick and swollen and angry, right? And that essentially, it also causes bronchospasm, which means the wall contracts, right? That's why we give a bronchodilator. And the steroids that the patient gets are ultimately reducing that inflammation that makes the wall less thick to allow more air through. COPD is an erosion of those alveolar walls, so there's less surface for gas exchange. The other issue in here is that there's a breakdown in the connective tissue, and these get very floppy, okay? So if you have a balloon, if you blow up a balloon, and you're holding on to it, you let go, what happens? You get that slow decreasing, that slow air movement out. Why does that happen? What's the physics of that? Anyone know? So air that moves fast creates low pressure. So that air moving fast through the end of the balloon is creating low pressure. That low pressure sucks the end of the balloon there together, and then the pressure opens it up again. So it's going open, close, open, close, open, close, open, close really fast, and that vibrating back and forth is the sound. Okay? Now, let's say, and that's what happens in emphysema, because we have floppy, no longer rigid alveoli. Now, if you had a balloon and you stuck a straw in the end of the balloon and then undid it, would the air move out of the balloon faster or slower? If you had a big, like a straw through there that's the same size as the balloon tip, faster or slower? Is the air going to come out? Faster, because that opening is no longer collapsing and opening over and over again. It just stays open because it's rigid. So the balloon with the straw is a normal airway. And then when you take out the straw and it is no longer rigid because you've lost all the collagen and other stuff from the disease state, that's the regular balloon. So this is why COPD patients have problems getting air out, right? Asthma patients have problems getting air out because their airways are constricted and swollen and angry. So they are breathing through coffee straw, stir sticks. COPD patients, whereas a normal is like a straw for like a milkshake. Asthma patient is breathing through coffee stir straw, and COPD patients are breathing through just like the balloon material itself, and it's all floppy and collapses, and so the air doesn't move through it very well. So, quiz question: rescue inhalers and maintenance inhalers are always separate. Yes or no? Good, okay. A little bit of controversy. It means we have some educating to do. Pro tip, as someone who's essentially been a professional test taker for like 10 years now, if a question says always or never, it's usually wrong. But so this is a new thing in the world of asthma called SMART therapy, which is single maintenance and rescue therapy. I hate that it's SMART therapy because it's single maintenance and rescue therapy. It's like ATM machine, just makes my eye twitch a little bit. But so classically, they were separate, right? You had albuterol, which is a short-acting beta agonist, which was your rescue, and you had an inhaled steroid, which was their maintenance that they took every day. Okay. And so those were separate, and those are some of the different inhalers that people had. So now we have single maintenance and rescue therapy, which is a long-acting beta agonist combined with an inhaled steroid. And that's brand name would be Symbicort. There's several others out there, but Symbicort is probably the most commonly prescribed one because it is now generic and cheap, and because it was one of the first ones that came out. So now we used to, the long-acting beta agonists, they acted a long time, but they also took a long time to start working. So they were like long on, long off. So they were helpful, but not as rescue because they took too long. Now the short-acting was helpful, but they were fast on, fast off, right? So the newer ones, what you have in a Symbicort, is they're fast on, long-acting, slow off, okay? So that's how it's different from the albuterol. It's formoterol, I believe is what's in Symbicort. But this is now, if you are having an acute asthma exacerbation, you can take puffs out of your Symbicort and feel better because it acts immediately, and also has the added benefit of, obviously they're struggling because they're needing a rescue shot, but it also comes with more steroid, which is going to give them even longer acting relief. So this is the new standard in at least adult asthma treatment, is they use the same inhaler for maintenance. So they puff once in the morning, once at night, and they can also take more puffs out of it during the day. And not only is it simpler because you can't mess up, that used to be the classic asthma call, right? When I was a paramedic was, oh, I keep taking my inhaler, but it's not helping. It's because they were taking more of their maintenance inhaler, not their rescue inhaler. And we're like, oh, silly, you had them mixed up. That's why you're not feeling better. Now it's not a thing anymore because it's just the one, right? And so I will encourage the patient to take more puffs of this, even like if I'm on scene with them, like before we can get the neb set up, I'm like, why don't you take a couple hits out of that, and then we'll get you some albuterol, and by the time you get to the hospital, you'll probably feel a lot better, okay? But so single maintenance and rescue therapy is the new thing. So other lung problems that we can have, I know you guys don't look at chest x-rays, but this on the right side, this is normal. This is all lung. And over here on this side, where'd the lung go? Any ideas? The lung is all collapsed down here. This patient has a massive pneumothorax. Yeah. Lung goes squish, make hard breathe, okay? So massive pneumothorax, okay? That's another lung problem that you can have. So we'll talk about the pump, fluid, and pipes. So the heart is the pump, right? This is why our CHF patients can have respiratory symptoms because they're not pumping the fluid around. You've got the fluid itself, the blood. This is why patients that become anemic become very short of breath, whether it's chronic anemia or acute anemia, right? This is why your trauma patients hyperventilate. That is why hyperventilation is one of the earliest signs of shock, because they're trying to compensate for the blood loss. So you're getting like hyperventilation sometimes even before you start to see tachycardia, and certainly before you see hypotension. And then you got the pipes. So, right, someone has a pulmonary embolism, right? That's a clogged pipe. They get short of breath. This is where the tension in a tension pneumothorax comes in. Like they're feeling short of breath because the lung is collapsed, but then the tension physiology is when it starts, the pressure inside the chest is so much that the blood vessels are starting to get pinched off, okay? So now, not only are we not able to exchange gas, but we're not able to get the blood round and round. Okay, so that's the pump, fluid, and pipe problems. So in CHF specifically, when the left ventricle is not able to keep up with the pumping, right? It's like you got you've got your preload, which is the tank coming into the heart, and then you've got your afterload, which is the tank going after the heart. And so if the heart is not able to keep up with the flow, you get a backup of the preload tank, right? And so like any tank, as the tank fills up, there's more pressure in the tank. And so fluid starts to leak out. And remember that picture of the normal capillaries earlier? So this is like our normal, this is our capillary bed in the lungs. This is our alveolus. But now there's all of this water that leaked out of it because of the high pressure, right? Because stuff is supposed to be exchanging across the capillaries. That's what they're there for. But when the pressure in the pipe gets too high, the water starts to leak out. And now the oxygen has to make it through the water to get to the capillary. And that's why those patients become hypoxic and short of breath. So this is, right, you got the lungs, you got the right heart feeding the lungs, and then the left heart. Right heart feeds the lungs feed the left heart feeds the body. Then the body feeds back to the right heart. So the preload is all determined by the right heart. The contractility is the LV, and then afterload is mostly determined by the blood vessels, right? That the LV is pumping against. So preload is filling the bucket into the lungs, and afterload is contractility and afterload are responsible for emptying the bucket. So if our lungs are full of water, we can either, we want to decrease the flow in and increase the flow out. So we can decrease the flow in by giving positive pressure and nitro, right? Because what's nitro do? Drops the preload. By the way that it does that is it makes all of those blood vessels relax on the preload side, on the venous side. So now that container becomes bigger, so the pressure drops, okay? So that's how we're dropping that. How does positive pressure drop preload? So when you're breathing in, any kind of positive pressure, whether it's non-invasive, patient's ventilated, whatever, you breathe in, you're having, instead of negative pressure in the chest, you have positive pressure in the chest. When you're breathing in and you're creating negative pressure in the lungs, your vena cava, which is feeding the right side of the heart, is also in the chest, okay? And normally you have negative pressure, and that's actually pulling on the vena cava and letting more blood flow in. If you have positive pressure in the chest, because the venous side is a low pressure system, if the pressure is high enough, it's going to start to push on the vena cava. And so now you're pinching the line that's returning the blood to the right side of the heart, okay? Which is the main mechanism by which CPAP, BiPAP is helping the patient. It's not increasing the pressure so that we're forcing the oxygen through into the lungs. That's not how it works, okay? Now, positive pressure also decreases afterload. Now, the way that positive pressure decreases afterload is the lungs are wrapped around the heart, right? Think about it 3D, right? The lungs are wrapped around the heart. Now, when the heart is trying to contract, it is contracting against the force of the blood vessels, okay? Now, if the heart is too weak, if we do positive pressure, well, now you have pressure on the outside of the heart. When it contracts, there's positive pressure helping it squeeze to empty. So positive pressure doesn't increase contractility because the heart's not actually squeezing any harder, but it does reduce the effort that the heart has to put in to get the same amount of work out, okay, which is dropping the afterload. Now, high dose nitro, if you're starting a drip at over 100 mics a minute, that does cause some dilation of the arteries to directly drop the blood pressure, and that does decrease the afterload, right? But the predominant mechanisms by which positive pressure helps a patient that is in acute heart failure is by dropping preload and dropping afterload. So there's less fluid coming in that the heart needs to keep up with, and the heart gets more bang for its buck with each contraction because the lungs are wrapped around the heart. So that's what happens when we do the BiPAP. Other fluid problems, anemia, we mentioned, and also shock, okay? Because they're vasodilated from sepsis or from anaphylaxis or something else, right? The blood's not getting to the tissues because there's a hypoperfusion state. Other big vessel problem we mentioned, PE, right? Clogged pipe, blood no get there, blood no worky. Okay, let's talk about history and physical. What are some history questions you ask patients that have a respiratory complaint? Or not? Okay, when did it start? Was this gradual? Was it acute? You ever been intubated? Ever been intubated? Good. What meds are you using? Do you have any diagnoses? Ever been in the ICU? I love it. Intubated. Good. Do you have any history? Do you have any meds? How often this happened? Cardiac history? Good. So I am a simple guy. They teach you all these crazy mnemonics for taking complicated histories in medical school. I still go with OPQRST, which is what I learned when I was an EMT. It works fine. That's what I still use. They teach you all these crazy things about this stuff. I'm like, none of them stick as well as what was steered into my brain as an EMT and a paramedic, okay? Which OPQRST is onset, what's the next one? Provocation or palliation, meaning the worse, better. What's next? Quality, radiation, doesn't really apply to respiratory. S, severity, and T, time. Which I also, I think of time as first time or last time. What happened last time this happened, or is this the first time this has happened? Is kind of how I think of that one. Because otherwise, I think the timing is usually covered when you're asking about the onset. But that's how I think of timing. But that's another good history question. Because honestly, when you're taking if you talk to the patient long enough, they will usually end up telling you what's wrong. And so, especially as an ER doctor, if they have something going on, I don't know, I'm like, oh, okay. Well, what worked the last time this happened? Oh, they gave me X and I felt better. Okay. You want to try X? Yeah, that sounds like a good plan, doc. All right. High fives all around. Don't overcomplicate it. Yeah, last time I got admitted to the hospital for like a week. Oh. Should I admit you to the hospital? Yeah, I think that'd be best. Okay. All right, and our physical, okay? We got breath sounds, obviously. What else? Anything else you're checking besides like breath sounds, respiratory rate on a patient with a pulmonary complaint? End tidal, okay, good. It's a good objective measure. Up SpO2, okay, another good objective measure. This is one you probably overlook, but I have started doing it routinely on every patient. Is I look at their lower extremities. And because you can get a lot of information from the lower extremities, right? Are they warm? Are they cold? Are they swollen? If they're swollen, is there pitting edema or not? Right? Like if I grab their calves and squeeze it and let go, and I still have a handprint there, I'm like, okay, I know what's going on. Is only one of them swollen? Right? So I'm like, hey, you ever had a blood clot? Oh yeah, I had one like 10 years ago, and I was, okay, you take a blood thinner? No, they took me off it after like 6 months. Okay. Right? Yes. JVD, accessory medical use, skin color, temperature, condition. The other thing for me at the hospital, and depending your role and how many people you have on scene and stuff, if a patient is sick and everyone is swarming the head of the bed and the upper extremities to like respiratories up there, putting them on BiPAP, and they're getting IV access and all this stuff, I can still access the feet and the legs, right? I'm just down there at the foot of the bed and I can actually start to get some information about the patient. The other thing that the lower extremities will tell you, even in a non-respiratory patient, is a lot about their ability to care for themselves or the care that they're receiving, okay? If you have someone that looks unwell and their toenails are all overgrown and look terrible, it's probably, I know, it feels going, yeah, no. Okay, but right, you're like, okay, they probably, this means that like bending over enough and the act of having to bend over and cut their toenails is too much for them to manage, okay? Whereas if you pick up some grandma from a home, like their own home, and their feet are all like nicely manicured and everything, or pedicured, either they're able to take care of themselves or they have someone invested enough in them to take care of them, right? So if you're like, you are way too frail, but your feet are nicely maintained and pedicured and everything, obviously someone is looking after you. So you also get some idea of like kind of their social situation from that, okay? So this is why the lower extremities can actually give you a lot of information about a respiratory patient. Treatments, okay? Bag valve mask. How many of you were taught to bag this way? Right? Everyone was initially taught to bag this way, right? This is what AHA teaches. You did your first BLS, like the CE technique. Don't do that, it sucks. Do what I call 2 thumbs up. Okay, so holding the mask seal should be a 2-handed procedure. Hopefully you have enough people on scene that one person can hold the mask seal and someone else can bag, okay? Anyone can bag, okay? The BLS firefighter can bag. The cop can bag. Just because they can doesn't mean they will, but they could. It is theoretically possible, okay? Right? Just squeezing the bag is not the critical procedure. Holding the mask seal is the critical procedure. So get 2 thumbs up on either side of the bridge of the nose going towards the mouth, and then reach around and pull that jaw up into the mask. This works remarkably better than CE, which is great if you're an anesthesiologist and you have to bag every patient solo and your entire job is all about finesse. But no, that's not us. Double ham fist, pull that jaw up into the mouth, and that way you're pulling the face into the mask. You're not pushing the mask onto the face. Positioning again, this is no good. We need ear hole in line with sternal notch. So push that head anteriorly. I usually take a blanket or a towel and fold it up into a little pad to put behind the occiput, and then 2 thumbs up to hold that mask seal. Especially when I'm running resuscitation and I can hold the mask seal and I can still tell everyone what to do, okay? And now I'm at the head of the bed and I have a good view of everything that's going on. And I can still tell everyone what to do holding the mask seal, which is, I think, the most critical procedure. Don't forget super plug, okay? So you also got your adjuncts. And now we can talk about non-invasive ventilation. So, comes in 2 flavors, CPAP, continuous positive pressure, and bi-level positive pressure, which is BPAP. BiPAP is technically a brand name. That's like saying Xerox or Kleenex, okay? The maximum pressure we ever want to do through non-invasive is 20 centimeters of water. Why is that? Anyone know? What happens if you bag too hard? Barotrauma potentially, but more commonly, yep, you blow up the stomach, right? 20 centimeters, there is a sphincter, which is, a muscle that does this, between the esophagus and the stomach. And the most pressure that can produce in most people is about 20 centimeters of water. So if your pressure goes above 20, now you're opening that sphincter. And this is why when you bag too hard, you inflate the stomach, because you're overcoming the pressure that sphincter can produce, okay? So CPAP, you have one setting, pressure, right? You can also, at the hospital, we can adjust what percentage of oxygen they're getting. Yours is going to be always 100%. And that affects the oxygenation. And in theory, CPAP is better for CHF than it is for COPD asthma. And that is because what we need is more time at the higher pressure right? Because remember, the goodness for CHF comes from that increased pressure, which is dropping preload and dropping afterload. The lower pressure doesn't really help us. So in theory, CPAP is better for CHF patients than for COPD patients. Now, this is what that positive pressure, that PEEP does.
Atelectatic, derecruited lung with no PEEP valve.
So they're bagging the lung with no PEEP.
PEEP valve is applied, and you can see over several breaths.
Now they have PEEP
recruited
to produce that positive pressure. So it's also recruiting
PEEP valve is turned
lung
up to 10, and the lung is maximally recruited. This gives you more safe apneic time and functional residual capacity. The PEEP valve is removed, and you can see immediate derecruitment and deflation of the lung.
For my fart sounds. All right, now BiPAP, you have two pressures. You have a high pressure, you have a low pressure. Now, the parameters that you set, it depends on the machine, okay? So there's a high pressure and there's a low pressure. Then the high pressure is called the IPAP, the inspiratory airway pressure, and the low pressure is called the EPAP, the expiratory airway pressure. Now, you either set directly the IPAP and the EPAP, or you set the PEEP and then how much higher you want it to go above the PEEP, which is called pressure support. So you, depending on the machine, you either set IPAP and EPAP, what's my high pressure, what's my low pressure, or I set my PEEP and how much above the PEEP do I want it to go, which is called the pressure support parameter. Now, there's advantages and disadvantages to both, but it really is just a manufacturer-dependent situation, which one you have if you have BiPAP. So, our oxygenation is determined by PEEP and FiO2, right? The PEEP, because that's what's recruiting lung, and the FiO2, because that's how much oxygen you're breathing in, okay? Now, the pressure support, or how high the IPAP is above the EPAP, that determines our tidal volume, right? Because you've got the lower pressure, and then how much help are you getting on each time you breathe in, right? Because the machine is trying to give the patient that higher pressure when they breathe in and that lower pressure when they breathe out. So whereas CPAP is just giving that higher pressure, which is at usually, it's just giving us that higher pressure at that 1%, so it's affecting oxygenation and the hemodynamics. This is giving us more of a benefit for ventilation because the pressure is alternating between high and low, and it's essentially trying to bag the patient. So, if common starting settings would be 10/5, so a expiratory pressure of 10 and a PEEP of 5. So either that's an IPAP of 10 and an EPAP or PEEP of 5, or a PEEP of 5 with a pressure support of 5. Does that make sense? How we get 10/5 from 5 plus 5? Okay. Again, just completely depends what equipment you have if you have BiPAP. Similarly, PEEP of 7 with a pressure support of 10 would become 17/7. Does that make sense? How we get there? Okay, good. I see heads nodding. So if we're titrating BiPAP and we want to fix oxygenation, we need to increase the PEEP, increase the FiO2, or increase the EPAP and the IPAP together. Why would I have to increase the IPAP and the EPAP together instead of just increasing the EPAP or the PEEP? So if your vent has you setting EPAP and IPAP, remember the difference between those two is how much tidal volume the patient's getting. And if they're ventilating fine, but I still have an oxygenation problem, so I want to increase the PEEP, if I only increase the low pressure, well now, and I'm not increasing the high pressure with it, well now that difference is getting smaller, which means they're getting less tidal volume, okay? So I have to increase those two parameters together. Now, if my machine is PEEP plus pressure support and I increase the PEEP, it's automatically doing the same amount of pressure support when you increase the PEEP. So that is an advantage, depending on how the machine is configured by the manufacturer, that it can be a little bit more straightforward for you to remember. You don't have to remember that if I'm turning up the low pressure, I have to increase the higher pressure as well, if that's what you're trying to do, right? So if we have a purely oxygenation problem and the patient needs more PEEP, we have to increase both pressures together, okay? Versus ventilation, you either increase the pressure support, right? Because that's giving you more pressure when the patient breathes in, or you increase the IPAP You leave the low pressure fine, and you increase the high pressure, the IPAP. Because now that pressure difference is getting better, or getting larger, which means the patient is getting more tidal volume with each breath. Does that make sense? Okay. Now, protocol-wise, right, this is BLS med director option. I think it should be on every ambulance. I think it should be, I don't think it should be an option. I think it should be just part of the protocols. And yeah, right. So things that make our eyes twitch in Massachusetts, right? Okay. So the only real, now the main thing to think about here are the exclusions, which we all know is like they have to be alert, they can't have altered level of consciousness because they're an aspiration risk, or there's something going on with the face where like the mask isn't going to work. But the other thing is apnea, right? The machine is not going to breathe for them. CPAP and BiPAP are what are called spontaneous breathing modes, which means the patient has to be breathing spontaneously. Now, the machines that we use at the hospital and the machines that you guys are using at National anyway, they have a backup rate. So if the patient is breathing too slow, then it will start ventilating the patient for them, right? So if they get below a certain rate, then it will essentially start bagging the patient. Because that's a ventilator mode. But again, it's completely dependent on the machine that you have. If you're doing BiPAP in the field, you are probably doing it with a transport ventilator. And so it probably has the ability to set a backup rate, which, plus minus. Now, CPAP, BiPAP, altered mental status, secretions, blah, 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 are contraindications in every protocol you ever look at. Personally, okay, so how altered is too altered? So here's the issue, right? So the main issue with the altermentation is what? What's the concern? Ability to maintain their airway, manage their secretions, aspiration, etc. Good. So the concern is that they're going to aspirate. Now, this is why you can't stick an altered patient on CPAP, BiPAP, and put them in a corner somewhere and ignore them, because they could aspirate, okay? Now, what is the risk of aspiration if I am sitting at the head of the bed with an altered patient on CPAP, holding a Yonker suction catheter, staring at them, waiting to see if they're going to vomit? It's pretty low, right? Because if they start to go, I'm pulling off the mask and I'm getting ready, right? So how altered is too altered? Altered that, like, if you're going to be sitting at the head of the bed in the captain's chair while the patient is on it and they're kind of out of it, and you've got that suction catheter, suction turned on, parked like behind their head, ready to go, it's okay, right? But by the time that we get to the ER and the initial resuscitation phase is over and they're gonna like not have 5 people in the room staring at them continuously while we're trying to get the patient going, that patient, once they're going to be left alone, they can't be altered at all, right? But in the acute resuscitation phase, where you are actively managing the patient and the machine is essentially just helping you bag the patient, that's fine, right? Because it's essentially a BVM. And what do we do with patients that are altered and don't breathe? We bag them, right? It's not different. So how altered is too altered? I'm pretty liberal with that, okay? But don't strap the mask on the patient and then set it and forget it and ignore them, right? Don't do that and then sit on the bench seat with your feet up, write in your PCR and ignore the patient, okay? But if you're gonna ride there and you're gonna monitor airway, that's fine. All right, we will take a break. Let's take 10 minutes. We'll come back at 1:15 and go through cases.